Good morning. Welcome to RBC Disruptors. I'm your host, John Stackhouse. Today's episode of our podcast is being recorded in front of a live audience here at RBC Water Park Place in downtown Toronto. Now, for those of you who are regular listeners to our podcast or here in our live audience, you know that we focus on technology and how it's changing everything around us. But when you think about that kind of disruption and maybe what a digitally enabled future looks like, I'm guessing your mind doesn't race to your local hospital. Well, it should. Healthcare should be seen as the biggest opportunity for digital disruption that we have in a positive way. It has everything that other sectors who we talk to, other innovators who we talk to, really yearn for. It has scale, it has data, it has money, and it's got a really, really big problem. It's creaking under its own weight, under our weight. The numbers just aren't working out for us. It has to be disrupted. When I was a kid, there were a dozen kids for every person over the age of 80. Today, there's more seniors than kids. A decade from now, 25% of our population is going to be seniors. The numbers just don't work out. And here's the real challenge. As we get older, and we're getting older, we get more expensive. Today, we're spending $160 billion a year on healthcare. A decade from now, that's projected to be $200 billion, and half of that is going to go towards the care of seniors. A quarter of the population, half the bill. We got to think about how to come to grips with that. Now, like most of you, I've tried to navigate the system for elderly relatives. It's a nightmare. I'll never forget being in a hospital ward one day with my late mother and trying to help a nurse read the handwriting on a diagnosis sheet left by a previous shift. You've probably all been in that awkward situation of trying to help an elderly relative remember the medications they were supposed to take that day. I mean, seriously, Franz Kafka couldn't make this up. And yet, in households across the country right now, this is reality. We have to do better. But you'll hear today that we can do better. We're joined by two great leaders in the healthcare space. They're real innovators who are going to talk to us about all the opportunities that we have with digital technology to disrupt the future of healthcare, especially for elders, and to help us better manage what we call, and what others have called, the Silver Tsunami. We're joined this morning by Mike Wessinger. He's the founder and CEO of PointClickCare, one of Canada's most impressive software companies that's leading some of the revolution in North American elder care. And Michelle DiEmanuele, who's president and CEO of Trillium Health Partners. Michelle is a former banking and real estate executive, senior bureaucrat in the Ontario government, and I should point out the inventor of North America's first money-back guarantee for government services. So Mike and Michelle, welcome to RBC Disruptors.
Good to be here.
Thank you.
Michelle, I've got to start with you and this idea of a money-back guarantee. Just in 30 seconds, what's that, and where do I sign up?
Well, first off, you all have it. The problem is that when we introduced it, we actually were delivering your birth certificate 99.8% of the time, on time, within 15 days. So we actually didn't have to give a lot of money back when we introduced it. But it really is an indication of trying to make sure public services are held to a high standard of efficiency, effectiveness, and fulfillment, which is what you do in banking all the time.
We aim for that. Let's get to the Silver Tsunami. Mike, I want to start with you because you've talked a lot about this challenge, and you've been at it for a quarter of a century, and we've seen some progress, but not nearly enough. What aren't we doing right?
Yeah, I think the part of the challenge, specifically with the senior care sector and technology, is, we have the advantage of this sector. It skipped an entire generation of technology. If you look at long-term care facilities, assisted living providers, it wasn't like they had to take mainframe systems and old school client server technology and replace it with something new and went through a full replacement cycle. I've been doing this my entire adult life, and we started in the cloud in 2000 before anybody called it a cloud or anybody called it SaaS. Nobody could even spell SaaS back in 2000. So we had the luxury of being able to go in with often a clean slate. There was really nothing in there, so there wasn't really much to disrupt. But the downside is there's a lot of work to do in order to implement technology for the first time, and there's no dollars to do it. The margins in long-term care across North America are razor thin. And so while everybody sees that there is a return on the investment for putting in technology, whether you're measuring that investment by healthcare outcomes or by margins themselves, there wasn't enough I to get the R in ROI. So there just wasn't dollars there. So if you look at the biggest market that we operate in was south of the border, and healthcare technology went through a huge transformation in the last decade. But most of it was in hospitals and physicians' practices. And you go, well, why did that happen? Well, there's the American Recovery Act, the High-Tech Act that put some $30 billion into healthcare technology for physicians and for doctors' practices. And what got forgotten was the redheaded stepchild of healthcare, which is long-term and post-acute care. So the only way that you are going to drive technology into those organizations is if you could do it at incredibly low cost, incredibly efficiently, and it had to produce immediately an enormous result. So the ability for people to make the investments in healthcare technology to get those returns was limited because there was so little dollars available to invest into healthcare.
So I see Michelle's nodding here, but I wonder before we get to you, Michelle, Mike, if you can just explain what PointClickCare is and what problem you're trying to solve.
Yeah, we're the operating system that would run long-term care facilities, long-term care chains. So if you're running a nursing home, you're running an assisted living, or a chain of those, or a home health agency, we would be the software that you would use to run your organization. So electronic health records, revenue cycle, the full financial application. We're really the core platform, like an ERP for senior care providers. And our software manages about 2 million lives a day. We're in some 3/4 of the assisted living facilities across North America and about 2/3 of the long-term care facilities across North America.
And you started this with your brother in the late 1990s. What inspired you?
It was my mother's a CPA. She was in the business, and their business was turning around distressed long-term care facilities back in the 90s. Through her connections, both my brother and I, I've got 3 brothers, all software engineers. I was the only commerce student, the black sheep of the family. And it was through her connections that we sort of identified this opportunity in long-term care to start putting automation into long-term care facilities. So back in the late 90s, my brother and I were putting in Novell networks and implementing the first technology, a billing and a care planning system into these long-term care facilities in the 90s. And it wasn't until late 99, early 2000, we said there has to be a better way. And what we now call cloud, we called it, what if we jammed everybody on one set of servers, delivered it over the internet, and charged them a cost per resident a day? Do you think that would work? We had no idea that we were catching on to what we now call cloud computing.
Okay, we're going to come back to the funding model because that's a real challenge. But Michelle, give us some background on Trillium Health Partners. People aren't probably not familiar with it or don't appreciate it, that it's one of the country's biggest community hospitals, 1.5 million people kind of in your catchment, in one of the most diverse places probably on the planet. It's incredible, the community that you serve.
Yeah, so just to give you a sense of Trillium, we service everybody from birth to end of life. Last year we did 272,000 emergency visits. If you take Sunnybrook, UHN, St. Mike's, and half of Mount Sinai, we did more emergency visits than all those hospitals put together. And so we have a very large community hospital that also is a regional cancer center. It's a regional neurosciences center, and it's also a regional cardiac center. And so it is, for all intents and purposes, it's not quite a community hospital, but it's not quite an academic health science center. We really do service a unique space. And with that comes great opportunities for us. And as you said, we treated 1.7 million patients last year. We're probably on track to get close to 1.8 in the next year or two. And I looked at my numbers yesterday, And about 60% of those emergency visits every year are people over the age of 60, and about 55% of them are over the age of 55 or 65. And when you get into 75 and 85, you're still in that 55% range. So you saw your numbers up there were 23% of growth in our aging population, but we can see that with technology, new sciences, people are living longer, and people are living longer with more complex needs. And then when you look at our, again, our population we serve being highly diverse, over 100 languages are spoken in the Mississauga, Brampton, West Toronto, which is a big service area for us as well. On any given day, we're dealing with not just healthcare, social determinants of health, but also a very diverse population. And you know, for all intents purposes, we treat the world in our hospital.
And the interplay, I mean, there's a reason we invited you both to be here, because the interplay between hospitals and homes is really important. Probably yes. Most people appreciate how difficult it is. It's like going from one country to another, and the lack of communication, the lack of tech interfaces is a challenge. But I want to get both your thoughts on what the opportunities are, what you're seeing. Michelle, stay with you, because you're a big spender on technology. You've got an enormous client base, as you said, but a big team trying to innovate all the time, and lots of cost pressures. I mean, we all know that we can't afford what is out there now, and certainly not afford that tsunami that is coming at us. So when you think about all those seniors coming into the hospital, usually for good reason, you don't want to turn them away, you can't turn them away. What opportunities are you seeing today in technology to better address it?
Well, I think one of the first things is actually not having people come to hospital. I mean, I don't think we wake up any morning wanting to visit our hospital. And when I think about particularly the relationship with long-term care, many of our seniors and residents in long-term care do require either hospitalization or some kind of specialized service during the course of any given year. And the opportunities with virtual care, and to be able to use technology for virtual visits. We have a couple of pilots that we're running with long-term care homes right now, and we're seeing a significant drop in having a senior come from a long-term care facility, come into an emerge department, go from emerge into a bed, and then eventually back, you know, maybe within 36 to 48 hours back to the home. We're eliminating that by having that connectivity with the subspecialty and specialty services right to the home, and being able to do that treatment and that work there. That is, for me, one of the most important things we're doing, because we often focus about the front door of a hospital. How do we, you know, within the emerge proper, or how can we use wearables or apps, etc. But to be honest, we need to focus on the back door of the hospital as well, to make sure that that flow is happening and that we are getting people out of hospital when they don't need to be there. And then, of course, not having them come in if there are other opportunities. We find people coming to hospital because it's the only place where you can get one-stop shopping for all intents and purposes. And we're trying to really create a hospital without walls to be able to offer that, whether it's in long-term care. We're looking at work with schools on suicide and death by suicide in our children. And we're looking at health hubs as a way to use technology to eliminate the need to come to hospital.
So Mike, I mean, you don't manage long-term care homes, but you certainly deal with them and support them with your technologies. From that end, on the other side of the back door, as Michelle called it, what is emerging, and what do you see as the biggest tech challenges that prevent us from providing better care for our elderly population?
Yeah, I think the idea is, if you can get seniors to the lowest cost setting as quickly as possible, and if you can avoid hospital stays, you know, any avoidable hospital day is going to save the whole system money. Any reduction of readmission back into hospital saves, you know, thousands, if not tens of thousands of dollars. And technology has a huge part to play in that. So if you think about it, I look at some of our U.S. customers where it's skilled nursing facilities, not the old folks' homes from 20 years ago. I have customers where their average length of stay for their patients is 8 days. They go and they get rehab, they go back to the place where they want to live. Well, the only way, if you walk into a skilled nursing facility, call it a Genis Powerback Center, it would resemble more of a med-surg unit of a hospital than your traditional long-term care facility that most of us would identify with. And the idea is if you're going to care for patients at that high acuity level, the only way you're going to do it is with technology. And so everywhere along the line, whether it's a highly skilled nursing environment, or it's a technology-enabled assisted living facility, or quite frankly, even technology in people's homes, the ability for people to care for higher levels of acuity is going to be supported by technology. So I'm going to take an example that, many of you might be able to identify with. So think about keeping people in home and aging in place. It's going to be the lowest cost setting. Now, if you get somebody who's got 5 or 6 disease states, 6 comorbidities, 24-hour care, everyone thinks home care is going to save the day when this silver tsunami hits. The reality is if you've got somebody who needs 24-hour care and they've got 5 or 6 disease states, it's not cheaper to provide 24-hour care in their home. It's just not. Put them in a congregate setting, it's going to be more cost effective to do that. That said, we've got people that are institutionalized today that don't need to be, and simple technologies can help with that. So think about, try to convince an 89-year-old male that they need technology in their home so they can age in place. Anybody have a grandfather or a father that age? The odds of you having them accept that are very low. However, let's say they've got a stroke, they spend a couple days in the hospital, move out to a long-term care facility, wind up back at home. Here's what typically happens. The third call to the daughter or daughter-in-law, and that's you universally takes care of seniors, daughters and daughters-in-laws. Sorry for those sons out there, it's true, you're not going to be the one. It's the third call, back in ER, dad skipped a med, missed his med, took too many meds, didn't take the meds at all. And if that third call says, Dad, if it happens one more time, you're gonna have to go to a long-term care facility. The reality is Dad doesn't need to go to long-term care. Dad needs help with his meds. Simple technologies to help with 2 things. One is help them with simple things like medication administration so they understand, and a platform to engage the informal caregiver, daughter or daughter-in-law, 2-3 time zones away, son across town, so they can help with, did Dad take his meds? It's 9:30. Do we know Dad took his meds? If not, is Dad following his discharge plan? Simple technologies, Internet of Things in people's homes, so you can provide that remote care, include the informal caregiver, are going to take a lot of cost out of the system. And it's going to be necessary when the silver tsunami hits.
So John, can I just offer up too? So we talk a lot about the aging population, but let's talk about those of us who, and I'm looking at this audience, who may become ill for a reason, and you're in a hospital for the first time. And technology can help us make sure that that population, which is more technologically literate and has an ability to self-manage sometimes better because of the nature of the acute episode that you're having, we can use technology to get you out faster, which also allows us to have the effective resource allocation for those who actually do need it, that complex patient that Michael talks about. So, for example, how we're using, your mobile phone and iPads, et cetera, to have you go home and do conferencing with us to look at a wound, to make sure it's healing properly, and to do other vitals and testing, and not have you stay in the hospital to ensure that those last couple of days you're stabilized, where you feel comfortable for you to go home, where we're not going to see you anymore, but rather to have you go home, continue to monitor you, and have clinics that have you come in and not stay in that bed. And that also allows for an effective use of resources for that more aging population that is more complex. So you can see how technology can help at both ends.
So social behavior is a big challenge for anyone trying to innovate. The technology can be amazing, but if you don't have behavior change, it's not going to be adapted. When I look at other sectors, or think of other sectors, entertainment moved quickly, and we see with innovation, it's always slow. It's like that ketchup bottle, and then a lot. We see it in banking. Very slow, people like their branch, they want to deal with people, and then suddenly everyone's comfortable, regardless of age, with mobile apps, because it's just a lot better and frees up your time to do other things. Are you, either of you, seeing hints of this in healthcare, or is it just the big ocean that we're all afraid to cross because we don't want to even think about self-caring? We want to be with a professional. Mike, you articulated the challenge really well, but I'm wondering what's the barrier in all of our minds and behavior to get us there?
Yeah, so I think we're seeing a big difference, especially with caregivers that are coming. And the expectation is now when they're coming in to do their documentation that they should be able to run an application on their iOS device, on their phone, and have it function like applications are used to, versus going to some monolithic green screen system that might be bolted to a wall. So the expectation.
And when you say caregiver, you mean the family or the professional caregiver?
So there's both, right? So the caregivers who actually come in to deliver care, in the average age of a PSW is in their early 20s. Their expectation is that they're not going to go to some monolithic beast of a computer system, that they're going to be able to do it on their iPhone. And if they can't, they're going to scratch their head and go, I don't understand, why can't I? But the other side of it is the expectation of families and the informal care network is, how do I get access to how can I engage with my parent or my loved one? I just expect that I can have access to what's going on with them in their life and to the caregivers, and their expectation is that there's some technology is going to be able to support that. So I think having the expectation is helping drive the innovation, saying, hey, how can we do family and patient engagement solutions that are that get people involved in the care circle for their loved one.
And Michelle, are you seeing this generational revolution either in your own staff or patients or both, or is it still kind of slow that people like the old way?
Let me take it from a couple of angles. From a patient population perspective, there's no doubt there's a generational gap. Some of the statistics I've seen is anywhere from 45 to 50% non-adoption of our seniors in using technology to be able to do self-care or managed care.
So 45% of the seniors coming into your hospital
wouldn't want to use.
No,
they want a face and a name, and they want to have a conversation about something. And
is that going down? Like a decade ago, what would it have been?
It would have been lower, but we've only started tracking it in healthcare, to be really honest, because we are behind in some of the adoption of technology. But on the younger side and on the professional caregiving side, if you are a hospital today that is not implementing or has implemented a state-of-the-art operating system, you will have trouble attracting new talent. There's no doubt in my mind. Our residents, we're just in the middle of an installation of our new electronic platform. And 5 years ago, residents coming in, new nurses coming in from other hospitals who had adopted, would say, I love working here, but the technology is killing me. And now we're really a magnet for talent because everybody knows we're going to have state-of-the-art, and this new generation wants that. They want it because it helps them do their work better. But in healthcare, they also want it because it's safer. There are so many checks and balances built into these new platforms that allow for such a degree of safety that we have never had before. So I would say, in general, that's the case. But the other point I want to make around the adoption of technology, whether it's caregivers, professional or otherwise, or patients, is like in your own business, you actually have to think about the entire business. And so if you start opening up with applications to your vital signs and your testing and your scheduling of your appointments, et cetera, and you know the list, what does that mean for the hospital and how does it have to change? I was in a meeting recently where we were talking about what we'll do next around my bedside information, electronic, and my chart information that you could access. And then the first thing somebody said was, well, we're going to need a call center. And you know what I mean by that, because you have a call center. I know when I have a banking problem where I have to call. Hospitals don't have call centers. And so we have to think about the adoption of technology in healthcare as a full operating platform and not just a intervention that we somehow get a false sense of security that we've somehow disrupted the system. And so in our hospital, we're looking at that from a total picture and somewhat, I would say, differently than other hospitals where we are not going to start with opening up information to patients. We're actually going to realign our own operating systems, our processes, our structures, and look at how we deliver the care so that we can actually promise something and deliver on it at the end of the day.
That's such a great point about call centers. At RBC, we now call them customer care centers.
That's right.
Which is not a euphemism because it requires
That's
a completely different skill set. We've had to move them geographically because we need people who really understand the customers who are calling in, not usually with a glitch that needs to be fixed, although sometimes that's the case, but they want to talk about a challenge that technology isn't fixing for them. They want a human to help them navigate. And I want to draw you out on the skills that are going to be needed, because we've been doing a lot of research on that front. But I want to get your thoughts first on the frontier technologies that we should be thinking about. There's always exciting technologies that you see on YouTube, or you go to a conference and you see robots doing this or that. How close are we, Michelle, in the hospital realm? And then I'll turn to you, Mike, to get a perspective from the long-term care home of this real revolution in both devices. Are we going to see robots doing things with wearables, and then also the software, which maybe is less exciting on YouTube, but sometimes more powerful? When am I going to see a robot, Michelle?
Well, we have a robot in we have two robots in two different ways. We have a surgical robot, and we have Tug, who delivers your medications throughout the hospital. So they're here. The issue is, when will it be the norm and not the exception? And and you alluded to this at the beginning, John, the financial constraints. I can't raise share capital. So I have to, through the allocations through government and good efficiency management and cash management, look at how I can create working capital to invest in these things. And in any given day, a hospital is probably carrying between $10 to $15 million in deficits around equipment needs. And then when you get to innovation needs, there isn't a lot. In fact, there's no money left over for that, because we're not funded in that way. So that is a really big barrier. And there's many things that we can do about that, and we're trying as a sector, but fundamentally we have to start thinking about the technology infrastructure investments in the same way we thought about bricks and mortar over the last 50 years. We need to start thinking about that capital investment in technology in a way that actually achieves this revolution that you talk about, John. But the other point I would make is we also have to be disciplined in how we choose what technologies. And again, I could walk out and go to my office today and I'll have several emails from excellent companies that all have a solution to solve my problem. And yet, how do we choose? And how do we choose as a sector that standardizes it across all hospitals, so that we don't create a mishmash of solution where in Windsor you get a different standard of care than you may get in Mississauga? And so these are some of the things that we're grappling with, and I think both governments and the sector together are starting to put in place some solutions to start to deal with this. And I would also say we've seen, both at the federal and provincial level, early investments in technology in a way that have been being helpful.
Okay, you're sounding like our CEO here when he's dealing with his tech team. I mean, we've got a lineup of fintechs probably going around the corner saying, we've got a solution for you. Just quickly, as a leader, how do you filter those decisions? Because most of what's on offer is probably exciting. It probably would work in some capacity, but you have to filter and make the strategic choice.
Sure. So I want to talk about it on two levels. I'll talk about it as a CEO in a hospital, and then I'll talk about something sector-wide. So as a hospital, obviously we use evidence. There's also a number of mechanisms within the sector that allow us to draw upon expertise and practice from other hospitals where technology is evaluated, et cetera. So we have that benefit to us. But fundamentally, I would say the biggest discipline that we use is to ensure that we're making the decisions that are based on what is best for a system as a whole, and not a physician who has a particular interest. That sounds logical, but it is quite revolutionary. And when you think about the other side of our business in fundraising, people want to invest in great ideas, and one of our best and most capable ways to raise funds is through our physician population, because they are great innovators in our system. And I would say they're primary innovators in many ways. And so we have to be very disciplined on system, evidence, and that it actually is going to deal with problems we have en masse and not isolated problems that we'd love to solve, but we have to make decisions. I want to talk about something else we're doing at Trillium, and you're going to hear more and more about this, and it's the Can Health Initiative, where we, along with 5 other provinces, we will have signed up all provinces, I believe, by the end of this year. where we're creating a marketplace to actually evaluate solutions made in Canada and to partner and match them to problems within hospitals and other healthcare providers, to be able to then disrupt the Byzantine procurement processes, regulatory processes, et cetera, and be able to launch these solutions more quickly, and many of them will be technology solutions. And so we're very excited about this initiative because it will allow us, we believe, to more effectively adopt technology, Canadian technology, and to actually solve real problems within hospitals across the country. It's not an incubator. These are solutions that exist. The problem is they can't get the marketplaces, and so they end up going down south. And we talked a little bit about that, Mike, beforehand. And so stay tuned, because I think you'll hear more about CanHealth.
Yeah, so Mike, I want to get your perspective on the technology options out there, but maybe you can first speak to the difference between Canada and the US, which we were talking about before, because you're selling into both markets, but the US, very different healthcare system, but also has scale and maybe more of an entrepreneurial approach to healthcare than that we've got. You're the vendor or the provider. What are you seeing?
Yeah, no, it's really interesting. The CanHealth initiative would have helped us out many years ago. It's a bit of a Canadian problem, which is you can't be a prophet in your own backyard. When you're a Canadian company, people just assume that you can't be that good because you're a Canadian company, and this is from Canadians. You don't have that problem when you go south of the border. I never had an issue when I went down to Ohio, to Illinois, Florida, Texas. They didn't really care where you were from. Could you solve their problem or not? It was interesting, selling into Canada, the comment was, well, you're a Canadian company. There's a broader market for this stuff. I should look there first, which is really interesting. So we were actually, until we had shown some real success south of the border, we weren't taking seriously in Canada. So hopefully that begins to change, because there's some great healthcare technology in Canada. The second part of your question was?
But that is such a challenge for our country. In fact, in healthcare, you can't be a prophet in both meanings of the word in this country. But we hear this across sectors, that people feel they have to go prove themselves in the U.S. to be taken seriously back home. I think that's changing, but not fast enough. Mike, I wonder what your message would be to sort of the Canadian decision makers who need to get their heads around this.
Yeah, I would say don't discount Canadian-based companies just because they're Canadian-based. There's some phenomenal technology. Any company that's going to generate scale has, of course, to be thinking of more than just the Canadian market. The Canadian market is not big enough to sustain any company of scale. But you would think the natural progression should be a success in the Canadian market, where you're close to home, you've got a customer base that should know, like, and trust you. Be successful in your home province, your home country, and then head south of the border. And I've seen so many companies that it's happened the other way around. They had limited success in Canada, they went south of the border. And generally, there was more dollars down there for healthcare technology. Decisions were made, infinitely faster. Things would get done quicker. So you understand why people would go south of the border quickly. But if the Canadian challenge, you could help Canadian technology companies move faster if you could make decisions quicker and not discount the fact that the company is Canadian-based.
So the other question I had added on to the first one was about the technologies that are at play, frontier technologies that you're starting to see in place in long-term care homes. How we get excited by the gizmos because they're fun to watch. They do have some benefits, but what are the real opportunities that you're seeing?
Yeah, I think the robotics are exciting, but I think there's the earlier things that are going to make a more dramatic difference. I think the Internet of Things and artificial intelligence are going to be enormous. So you think of the Internet of Things. I mean, everything has a chip in it now. Everything's being recorded. 5 years from now, if you think that within a 5-minute period, if you're living, especially in an institution, that 60,000 pieces of data won't be collected on, you're mistaken. They will be. It'll be stuff that's in your walls, in your bed, in the toilet, in pills you might swallow. There's going to be so much data, or things you're wearing, so much data that are going to be collected on these on this aging population that are institutionalized. But when you've got all that data, you can't act on that data. You need machine learning and artificial intelligence to rationalize that and understand that, and then get it to a point, not just more data or alarms and bells, bring it to a decision point where those things that human beings are uniquely qualified to do, which is critical decision making with the right information, that's going to be absolutely critical in this market. I also think that taking machine learning, we've got at any given day 2 million patients that are being managed with our software, but over the years we've got tens of millions of patient records, and in some cases, some of the data on those patients, it's millions and millions of data points over 5-10 years. To be able to start taking machine learning and looking at population health applications for that and starting to standardize care delivery, there's a huge variance of care in long-term care. And if you can say, look, based on everything we know and all the data we've collected over the last 20 years, we think that this is the right protocol to follow for an 89-year-old female that has these four comorbidities. Too often, the standardization is, it's the physician discharges and they go, just follow this protocol. And this protocol may work well for somebody who has COPD that is the 38-year-old male. But when it's an 89-year-old female with 7 comorbidities, it's exactly the wrong thing to do. So being able to go through, look at all of that data, apply data science to it, use analytics to provide real-world evidence to standardize how it is we care for seniors is going to take a lot of the cost out of the system.
But Mike, who's going to do that research? Because that costs a lot of money, and as you referenced earlier, the model is not there. For the ROI is not there because the I isn't there.
So we're trying to do it as a commercial company, trying to do that and trying to figure out. It's always creative finding ways to monetize that. But ultimately, if you can take cost out of the system and inefficiency out of the system, ultimately you're going to be able to find a payer. And it may start with the provider. It may start with one of the service providers that delivers services to our customers. But ultimately, you're going to find that payers, whoever's paying the bill, is going to be motivated in some way to underwrite these things. We just need to find clever ways to do it.
So tell us a bit about where you want to take PointClickCare. I mean, it's a company that has 1,200, 1,300 employees. It's an amazing Canadian success story that not enough Canadians know about. But as we move deeper into the data age and with all that machine learning is giving us the capabilities to do with that data, where do you see PCC going?
Yeah, I think we're going to continue to expand. I mean, if I look at our customers, they only have adopted about a quarter of the problems we can solve for them. So they may use us just for basic electronic health records, medication management, and to get bills out the door. But there's so much more we can do for them. So we really have to continue to push to drive more and more adoption within our customer base. And there's 2 limiters. One is they've got to get the funding, so the return has to be measured in days and weeks, not in years. So we have to relentlessly simplify how quickly we can implement those things so they can adopt really a full footprint of technology. The second piece is really taking all of that data that we've been collecting for years from our customers and turning it into actionable insights, whether it's for managing an individual's health care and connecting them across the continuum, or it is trying to change the way you care for populations of people. One of the things that we've done recently, and this was really driven by a sea change in how providers are funded south of the border, which is they started to get penalties for above average readmission rates. A readmission could cost anywhere from $20,000, $30,000, $40,000. So somebody goes from hospital, goes to, say, a skilled nursing facility, they bounce back, and it blows up the whole economic model. So they started to put penalties in place that if you have above average readmissions, we're going to hold back some of your funding and give it to those people who have a lower readmission rate. Well, behavior changed overnight. And people started saying, wow, we now care what happens when they leave the 4 walls of my hospital and they go to that skilled nursing facility. Well, what's going on with them? I need to understand what's going on when they leave my building, whether they go to home health, their home, or to skilled nursing. Now, typically the highest risk for them was ones that were going to a skilled nursing building, had 5 or 6 comorbidities. If they came back, they knew it was going to be expensive. It was bad news. So one of the things that we started to do is starting to connect them across the continuum, saying, look, we can give you insights so you can follow your patient after they leave here. You've got 4 patients that went to this skilled building, 7 that went here, 9 over there. here's a dashboard in real time. You can manage them in real time. And before they arrive at the long-term care facility, you've already reconciled the meds. You've already sent over everything electronically, not a binder with a bunch of paper that's on their chest when they come in on the gurney. Everything comes electronically. They can reconcile the meds before they even get there. And then the hospital can connect with the long-term care facility and be identified everything that's going on. So for us, it's really trying to connect across the continuum, allow for care coordination right across the continuum. So that's a big growth area. And I think the third one is we've really opened up our platform to democratize and unleash innovation, where we just opened this up last year, where we publish our API so that third-party vendors, whether they've got an Internet of Things device or they've got an application that they want to connect to our core application, or they've got a technology-enabled service, where they can build it on our platform. We've got some 700 companies that are now in the program developing and innovating on our platform to solve real problems of healthcare. So really unleashing innovation.
That's a fantastic outlook. I've been next to those gurneys with those clipboards on it. It's just crazy. And Michelle, I'm wondering, I mean, that sounds so obvious and from a lay perspective, something we should just do. There's probably reasons we're not doing it, but how close are we to that sort of integrated, data-driven model, to especially for elderly patients who are in and out?
Yeah, I'm not as optimistic as Mike would be. I think you said 5 years. I think there's a lot more that has to happen to make that happen.
Why?
So everything, we talked about the financial investment, so I'll leave that aside. Secondly, you've got regulatory issues around how we share information. I have so many workarounds for the data sharing that occurs with all of our various third-party vendors. It looks like this massive web. That has to change, and I think there's certainly indications that it will, but it will be slower than we want it to be. There are issues associated with just the technology itself and the privacy issues. On any given day in our hospital, there is a cybersecurity issue going on somewhere in the world in healthcare, and definitely somewhere in North America in healthcare. And so we're constantly thinking about this interconnectivity of systems and how are we protecting ourselves from that, and the cost associated with what is just a basic need before you can start to open your platforms up and invite folks in. But fundamentally it is going to happen, and I would add to what Michael has said, because what he said is absolutely correct, and it's the right model, and I believe AI will not only solve some of our issues around how we treat patients, the safety, the quality, the experience itself, but it's also going to help us. I think it'll help in human capital issues that we have, and the shortages that we're seeing in human capital in healthcare. And so it's a very positive thing, but it's going to happen slower than we would like for all of those reasons: financial, regulatory, the whole security and privacy issue, and so on.
So you're making me think of what that cheesy Tom Cruise movie, what was it called, The Day After Tomorrow, where it's just like, or like Groundhog Day. And when I was caring for my late father, in and out of a retirement home to a different hospital all the time, it was just like that. It's crazy. Like every entry into the hospital, you're starting from scratch.
Yeah.
Why? And we're happy to share our data for obvious reasons. So why can't we collectively make this happen?
And again,
what's the obstacle?
I can't. Your data.
You want to make it happen. You want to make it happen.
I am charged with protecting your health information, and so many of the existing regulatory barriers don't create standardization around the protection of that information. What one hospital is declaring your personal identity may be slightly different, even around your SIN numbers, your birth dates. Do you carry the birth date, or do you carry the age of the patient, as one example? And so we've got a lot of work to do. And so in our hospital, where we will be modernized, where you come in any door, you won't have to repeat that story again. It's all on the electronic record. You're not carrying your binder on your chest, but then you're going to walk across the street and maybe go visit your elderly parent in a long-term care facility that hasn't made that investment. And so we're printing out that information and sending it over on paper, or at least we're faxing it even still today, and we're emailing it in other instances. So that concept of an interconnected system is not there yet. So while you're seeing progress, and this Canadian company is, a standard bearer for us in this country, we're seeing progress in so many ways. It is progress that is both disjointed and incremental. And where you get that from a both public policy perspective and from an operating perspective, you get slower progress. And so, that's why things like what I've talked about around CanHealth, partnerships. Michael, you didn't mention partnerships around your plan until the very end. But for a hospital that is rich with diverse data in an AI world, we should be the primary partner for AI, certainly in this province, if not the country. And so
what do you need to?
I don't need anything. We are going to be that. We can be that. But that partnership and that sharing, we will have to do workarounds at the same time as we're trying to get legislative change, regulatory change. And I actually believe the easiest part is the investment side, Michael, that with good ideas and good partners come good opportunities. And so we're certainly not finding on the innovation side it difficult to find partnerships where there is capital involved to be able to develop solutions, whether it's in AI or machine learning or other works that we're doing. On the other side of things, though, as we work to try and change the existing delivery system in Ontario, that certainly is slower. I will say, I believe we have a government today, and not a political statement when I make it, or a partisan statement, but we have a government today that has said the existing system does not work. And they have disrupted it, they have unstuck some things, and this is good for us. This gives us now an environment in which to go back now and replace things in a way and augment it in a way that actually can create progress. So we're quite excited about that.
And what simply has that allowed you to do, that kind of disruption? How has that allowed you to innovate?
It's allowed for new solutions to be on the table. Solutions, for example, related to funding, where we were told we could only use certain funding in an envelope for some things. We've been able to move that funding into other areas, like on virtual care as an example, to be able to find the funding to start a pilot that proves, in fact, what Michael talked about, which is less people coming through the emerge, less people staying in the hospital who otherwise could have stayed at home or who could have stayed in their long-term care facility safe. And just to put a point on that, the average hospital cost a year for a bed is anywhere between $250,000 to $400,000, depending on the type of bed you're using in a hospital. The average cost of a bed in long-term care is, I'm going to say, between $30,000 and $40,000 a year.
A tenth.
That is a staggering difference. And so every person we keep out of hospital who doesn't need to be there allows for us to deal with that silver tsunami and allow those people who need to be in there in a hospital bed, being treated, being cared for, different word, and not in a hallway. And again, to come back to Trillium, on any given day, we are treating between 100 to 150 patients more than we have beds. And we have almost 200 beds outside of our hospital in Halton, Runnymede, Humber, because we don't have enough space. We are the poster child in so many ways for what's happening in the system. But we're also the poster child for disrupting it and changing it in all the ways that both Michael has talked about, John, you've alluded to, and I've talked about with respect to both technology. But I don't want us to forget the other side that you talked about, which is the human side of it, and ensuring that we're using technology for what I'll call the more transactional things, so that we can apply that human capital to the human things that need to be done.
So we've got just a few minutes left, and I do want to get your thoughts on the human capital challenge. I think we're sort of in the early stages of a virtual care revolution, partly because of the just the financial logic of it, but also, with all due respect to hospitals, it's not a great experience. So no one wants to go to a hospital, and the more that we see these other options, it's going to be like smartphones. Suddenly, wow, those make a lot of sense, and you just get on with your life doing things that seemed kind of weird maybe when smartphones first came out. So on the skills challenge, because as I said, we've done a big Humans Wanted research project, long-term research project looking at the future of work. We're doing a sector deep dive with healthcare and looking at the challenges and opportunities, because healthcare is the fastest growing jobs creator, or has been over the last decade, and there's no indication that that is going to slow, but the skills needed because of these technologies are changing. So Mike, I wonder if I can start with you and seeing what you're seeing on the front lines of long-term care. What kind of skills are starting to emerge that we're going to need more of, and how do we ensure we've got more people with those skills?
Yeah, I think the challenge is you need to make the job more attractive. In a full employment market, when you're making near minimum wage, and you think about it, if you're a PSW in a long-term care facility and you rode the bus for an hour to work, and the first thing you did when you got there was change an adult incontinence product, and somebody offered you 25 cents more an hour to go work at Walmart, what are you going to do? You better really, really love that job, and it better be something you're deeply passionate about. Otherwise, you're going to leave. So it's going to be an enormous challenge. Older nurses are aging out, so attracting people to the sector is going to be hard. Keeping people in the sector is going to be hard. I think universally, if I look across my customer base, if it's not their number one challenge, it's their top two challenges. I have customers that can't open up their business, they can't take another home care patient, they can't open up a new wing of their assisted living facility because they can't find the staff to be able to do it. So I think
in Canada or the U.S. or both?
Both. It's both. It's universally true. And so from one of the areas from a technology is, we know that that if you don't provide a good experience in dealing with technology and start to remove the type of things, people who are attracted to healthcare probably have a big EQ. You give them a lot of documentation and paperwork and administrative work to do, they're not going to love the job and they're not going to stick around that job very long. That's why you even mentioned that having modern technology that people can interact with is an attraction, and if you don't have it, it'll steer people away. So I don't know what the solution is to try to attract more people into the industry. It's going to continue to be a challenge, but all of the ones that we have in the industry, we need to try and keep and have them focused on the things that humans are uniquely good at, which is empathy and working with people and recognition and critical decision making. Remove all of the stuff not have humans do computer work that can be done by machines. I think that will be helpful. But ultimately, the bigger problem is we've got to change the caregiver to patient ratio, because today, if you just fast forward when the Silver Tsunami hits, and it hasn't hit today, people go, wasn't already here? The gray tsunami is already here. Well, it isn't, because the people start to consume long-term post-acute care services about the average age of 83. Boomers aren't 83. The reason why the demographic of 83-year-olds has been pretty flat for the last decade, and the reason why was nobody was having kids during the Depression. That starts to tick up this year and hits like a wall in about 4 years and carries on for decades after that. So if you think we have a challenge today, it's only going to be worse, and the only way you're going to solve that problem is if you change the caregiver to patient ratio, and technology and innovation are going to be the keys to getting that done.
What's the ratio now, and what do you think we need to get it to?
It depends on what the profession is, and it depends on what the setting is. But I look at simple things like care coordination that we have with some of our hospital customers who are trying to manage their post-acute population after they leave the building, and their ratio is about 1 to 20 or 1 to 30 lives that they can manage after they leave their hospital, and the numbers they need to get to are going to be something like 1 to 200. It's going to be an order of magnitude change for them to be able to afford it. So in a lot of areas, this isn't we need to be 20 or 30% better. We're going to have to be order of magnitude better.
And that requires us to look at technology in through a very different prism. That it has to be a kind of a force multiplier for the scarce number of people who are in the system. Michelle, we're running short on time, but I know this is a passion of yours as well as a concern, and I'm wondering, from a hospital perspective, how you see the skills crisis and what we're going to need most as the tsunami hits?
Okay, so we employ 12,000 people in our hospital, and so we're seeing all the trends that people talk about, but I actually think it comes down to some simple things that we just have to keep focused on, and I think Mike has again alluded to some of these. Number one, we have to create environments where people can be successful in their work, and how do we use technology to help, not hinder. We have to continue to have great leadership in organizations where people want to come to work with people who really get the best out of them. We have to be investing in career ladders for PSWs. If you're a PSW in the community, where do you go next in healthcare? And within a hospital, we at least have those ladders that people can work through, and we need to extend that beyond the hospital walls so that people see themselves as having a multiple decade opportunity and not just an intervention or a timeout in healthcare. We need to also look at policies and practices around how people do work. I would say healthcare offers for nursing and others one of the most flexible work arrangements where you can get multiple days off because you've done 12-hour shifts. And so there's lots of positive about the healthcare environment from a work perspective. But fundamentally, I think, John, you said that we are seeing a net need in healthcare. When people are getting worried about AI being a net drain on job creation, we don't see that in healthcare, first point. And then secondly, I would say in healthcare, it's also recession-proof. And so that allows for, I think, young people who are really worried about the next 20, 30 years of their life around what they're seeing in the world. Healthcare, I really think, offers variety, complexity, reward, personal reward around being able to really marry your values as an individual, and we do not sell that enough in what we do in our sector.
One of the things we're finding in our research is all that is true. We're going to need hundreds of thousands of more healthcare workers over the next decade. We're going to have all sorts of new technologies, but we're going to need more people. And it's an important sector for people who are being disrupted in other sectors to bring a lot of those human skills into healthcare. And we're going to have to rethink how we train people through their lives for mid-career transitions into healthcare. So some really important challenges, but opportunities as well there, which we could talk about for ages. This has been a terrific conversation, but regrettably time has been our enemy here. If you've enjoyed the conversation, I'd encourage you to subscribe to our podcast. If you just go to your favorite podcast platform and you'll find and look for RBC Disruptors. If you like what you hear or you have thoughts on us, give us a review. Unless it's going to be a bad review, don't give us a bad review. But give us a review, give us a rating. That helps us. It helps our podcast reach a bigger audience. And we're trying to inform and inspire the country on these important challenges. So we want that audience for RBC Disruptors to grow and grow. But Mike and Michelle, thank you so much for being here today, and thank you for all you're doing to help us cope with the Silver Tsunami and to make sure that Canada is an innovation leader in this critical space. It's been great to spend time with you. Thank you. Thank you.